See, all right, here we go. So this is a case of renal tuberculosis, and whenever you see calcified things, immediately start thinking tuberculosis, where calcification in any organ, calcification in lymph nodes, just think tuberculosis first and foremost. And so this one is obviously an extreme case. There is just massive calcification of nearly the entire kidney. There's a little remaining parenchyma, and there's actually a fluid collection deep inside it that probably represents a tuberculous abscess. So this is one of those few cases where a 3D actually helps because the whole thing is so dense. So it really gives you a sense of the extent of calcification there. So the end stage of renal tuberculosis is a phenomenon known as putty kidney, where the kidney just becomes a macerated ball of goop. And this isn't quite that, obviously, because so much of it is calcified, but I think this is pretty close to a putty kidney. That's probably a reference to that sludge we're looking at there, that hypodense region centrally. All right, so that is a case of renal tuberculosis, and there's the 3D. Again, I don't do too many of those. They just don't seem to help that much, but that one's pretty cool. All right, renal tuberculosis. This is one I've seen with some frequency. And the disappointing thing is it's always done non-contrast because these patients typically do present in renal failure. So both kidneys are enlarged, and even on this non-contrast scan, you can appreciate that there is some parenchymal striation. In fact, the harder and more you look, the more you can see that there actually is sort of a pyelonephritis-looking striation affecting both kidneys. So bilateral renal enlargement and essentially the imaging appearance of bilateral diffuse pyelonephritis with striation involving both those kidneys. I always remember this was one of the first of these I saw. It dates back to my private practice days. And I always remember saying to my friend Gordon, who was particularly sharp, I said, "Hey, what about renal lymphoma for this?" And he rolled his eyes and he said, "The most common presentation of renal lymphoma is bilateral renal masses, and lymphoma in the kidneys does not tend to infiltrate diffusely such that it would have this appearance." And I thought, huh, that's weird, because I always thought of lymphoma infiltrating things and just generally enlarging them. And I went and looked it up, and he's absolutely right. So typically, lymphoma in the kidneys will be multiple renal masses scattered about, almost looks like renal metastases, which I guess to some degree they are. So this does not look like renal lymphoma. So bilateral enlargement, diffuse striation, HIV nephropathy. That's a direct infection by the HIV virus of the renal parenchyma. It's actually not a secondary infection. All right, this one is a case of schistosomiasis, and you will see this. It's apparently very common in Somalia, and the more Somalia becomes a failed state, the more immigrants from Somalia we receive, and they do bring schistosomiasis with them. So this one, it's funny, when I actually used this for the Jeopardy game a couple weeks ago, and everyone started vomiting XGP when they first saw the kidneys. And that's not unreasonable, right? You've got a central stone, bilateral hypodense enlargement of both kidneys, which actually in this case turns out to be predominantly hydronephrosis. But here's the thing that tips it over into schistosomiasis: ureteral calcification and bladder calcification. Those both are very specific findings for schistosomiasis. You won't see this in other conditions. Okay, so there is bilateral hydro, which is quite impressive And there was a central stone on the right in the right kidney, but there wasn't in the left kidney. And again, that should make you really wonder, hey, could this really be XGP? Because without a central stone, you can't call that left one XGP. And honestly, the right one is just a nephrolith that isn't centrally located and doesn't appear to be obstructing. A very nice view of that bladder and ureteral calcification. Let's look one more time. So you can see the ureters are obstructed above the level where they're calcified. And then you've got that calcification both posteriorly and in the left aspect of the bladder. So that is urinary schistosomiasis. All right, this is one of my favorites. I love the sacroiliac joints. It's the internist in me. When you can spot sacroiliitis, it really hones your differential possibilities, and it can allow you to make a diagnosis that you otherwise wouldn't have. Right, so in this case, it looks like just a garden variety stone. You can see you've got hydronephrosis on the right, and that, again, I hope everyone is noting and would call, because it's not actually subtle. And there is a slight dilation of the right ureter as well. And then lastly, down here, right at the ureterovesicular junction, we've got a partially obstructing stone, and it's gorgeous, isn't it? You can see that jet of contrast proving that this is not entirely obstructing. And here we are on the bone windows where you can see that jet perhaps a little better, and the stone. So here are the sacroiliac joints, and note, we don't have the thin pencil line of normal cortex. The cortical line there on the iliac aspect of the sacroiliac joints has become fuzzy and blurred, and compare it to the opposite side sacral cortex, which looks essentially normal. So the joints appear to be slightly widened, and note, these changes are predominantly in the anterior aspect of the sacroiliac joints. That's the synovial portion of the sacroiliac joint. And so inflammatory processes in general will concentrate in the anterior aspects of these joints. This, of course, is not inflammatory. This is hormone mediated due to hyperparathyroidism. And that's the entity that tends to give you this asymmetric iliac side subperiosteal resorption, right? So those are just classic changes of hyperparathyroidism in the sacroiliac joints. And so that allows you to say, aha, this is not just a garden variety stone, right? This is actually hyperparathyroidism causing nephrolithiasis. All right, and there is that stone and that ureteral jet proving that it is not obstructing the ureter. And really tune yourself to the asymmetry of the collecting systems there. Again, that right hydronephrosis, I do not consider to be particularly subtle. Just a little difference makes all the difference diagnostically. So there are those sacroiliac changes. We'll let that run a couple times. So you can see that they're predominantly on the iliac side, and compare that sacral cortex to the iliac cortex. And the finding is actually pretty obvious. So that's hyperparathyroidism with subperiosteal resorption in the sacroiliac joints. All right. So this is an interesting case from my ER days. So this patient was a youngish male. He was 20, early 20s, and he came in AFib. So you can see there are classic multifocal, bilateral, wedge-shaped hypodensities extending to the renal capsule. These are classic microemboli. And this patient came in AFib with a heart rate well in the 160s, 170s. And he reported having done cocaine, and then his heart started racing. And it had gone on for a little while, an hour or so, before he came to the ER. And I was very careful in establishing the time course of all this, right? Because you can convert atrial fibrillation and flutter sometimes with carotid massage because of the vagal stimulation. And so I had never successfully converted someone with carotid massage, and I always kind of rolled my eyes when the internist talked about it because I think, man, that never works. But I decided, hey, it was short term enough. I'm going to try it. And so I tried it, and boom, his heart rate dropped down to 100 or so, and regained a normal rhythm. And I thought, wow, it worked. And then about 10 to 20 minutes later, he started hollering and complaining of bilateral flank pain. And so we shipped him to the big city, and he got this CT. And yeah, I had converted him, and incredibly, he had been in AFib for long enough to have formed an atrial appendage clot, most likely. And when I converted him back into a normal rhythm, he shot that clot out, it fragmented, and it went right into his renal arteries. So pretty impressive on the coronal. You can really see the extent, again, bilateral, wedge-shaped hypodensities extending to the renal capsule. That is just the classic appearance of microemboli. So there they are. Pretty neat to have just witnessed the whole sequence of events and know exactly what had led to this. So incredibly, this was my lesson that carotid massage can in fact work on occasion. Pretty big one in that right kidney. You can see there's a pretty significant chunk of cortex taken out there in the medial inferior aspect of the right kidney. All right, that is converted atrial fibrillation resulting in bilateral renal infarcts. All right, this one is very interesting, and I missed this finding. Honestly, it's pretty tough, but I did not miss the hypodensity of the left kidney. Clearly, the whole left kidney is just out. And if you look at the left renal artery, there it is. And it also is occluded, right? There is hypodense filling defect there, suggestive of a thrombus. And of course, here you're thinking, well, could this be thromboembolic? And I went up and looked in the heart. The heart's perfectly normal. There's no intracardiac clot. And I was stewing over it and said, well, I guess I just don't have a source. And what I should have thought of is a local entity in the left renal artery, perhaps giving rise to, say, an aneurysm or a dissection, giving rise to thrombosis in situ. And if you look real carefully at that right renal artery, or the left renal artery, you can see it actually is a bit of a corkscrew. It's got a little bit of a circuitous course to it there distally, and that is the classic appearance of FMD, fibromuscular dysplasia. And so ultimately, and there you can see that little squiggle of the left renal artery. And so what this was a dissection. Patients with FMD are at risk for renal artery dissections, and the renal arteries, of course, are a favorite place for FMD to involve. So yeah, the angiographer called me after going in and trying to clear this, and he said, hey, you missed that FMD. And I said, well, you did the angio. And he said, yeah, I saw it on the scan. So you can see that the renal arteries typically just get right down to business, right? And they go straight out into the renal hyla. And so that really should have caught my eye, that squiggly course there of the left renal artery. So that was FMD with a focal dissection resulting in occlusive thrombosis of the left renal artery.